speak about Dr. Khushbu. She is the expert today for our HRCT session. She is the consultant radiologist, the founder of Aizen Imaging and Interventions, multi-modality state-of-the-art diagnostic center in Noida. She is MBBS MD FIVR and would be pleased to hear her. Thank you.
A very good morning, everyone. It's indeed a great pleasure and honor to be in this city and be talking about interstitial lung diseases and how as a radiologist we can make a difference together with the pulmonologist, rheumatologist, and as Dr. Gaurav very clearly emphasized the importance of the multidisciplinary discussions, which are indeed the need of the day. So we will start with some things which are very basic. As a radiologist, what we mean by certain terminologies and how just the play of those terminologies, I think it is, and how will the play of those terminologies and a mention of those terminologies make a difference. So we begin with something very basic. What is an HRCT? So whenever we are talking about HRCT, we always discuss that whether it's a scan taken on a different machine, do we need certain specific CT scanner to do it? So no, but yes, it's a different acquisition. So in front of you there are two images. Obviously there is a difference between the two images, both have been acquired on the same machine. So first is a routine CT scan where a lung windowing has been done, we've just changed the window. The second is an HRCT scan. So earlier days the acquisition also used to be an HRCT, but now we are looking at it in a context that with the current machineries, at least everyone has a 16 slice scanner. So acquisition is normal in all patients. It is the reconstruction which needs to be HRCT. So once a volume acquisition has been done, even if you did not write an HRCT to begin with, you can always go back and ask them that we need an HRCT recon. And it is a moral responsibility also of every diagnostic center now that even if you write or not an HRCT, if a CT scan has come, the HRCT acquisition or the reconstructions need to be done. So that is something we need to be very sure that it's not a different acquisition, it's a reconstruction. Scan is acquired in a similar manner for all patients. Every CT scanner, unless it is a conventional CT scanner below a 16 slice, you may not have to acquire it in that manner. Now what is the need for HRCT? Obviously the need is because we are talking about something like the lung parenchymal interstitium. Lung parenchymal interstitium is an integrate mesh of the entire scaffold between the alveoli and the bronchi. So in order to be able to see what is happening into this interstitium, nothing less than a high resolution CT scan can suffice. It's very, very, very important that beyond acquisition, beyond the machinery, the quality of the scan. By quality we mean that a scan needs to be done with an adequate breath hold. So imagine when you are also auscultating a patient, you do say lambi saans lijiye, rok ke rakhiye. The same thing has to happen on a CT scan. You cannot acquire a CT scan while the patient is free breathing and try to interpret it. So adequate breath hold. Then again, assessment of the CT scan in end inspiration and end expiration is both important because that gives us a sense of how the lung is behaving while it's inspirating and when it has expirated. The acquisition today has to be a volume scan. Gone are the days where we had the conventional 4 slice, 8 slice machine where you used to cut them in pieces and the information in between was lost. So now it's a volume scan. Once you acquire, then you can then reconstruct and you can get sagittal, coronal, all reconstructions on it. So it has to be a volume scan. Prone scan is required, especially when we are talking about interstitial lung diseases, the early interstitial lung diseases, where prone scan is such a phenomenal tool that it, from calling a patient absolutely normal to calling a patient as having ILD, that there's a huge difference, and a prone scan is one single step which helps us say that with confidence. Then we talk about the reconstructions, which are all HRCT reconstructions, and we need to know. Having said that, and once our scans are done well, we need to understand what is normal and what is abnormal. Now when we look at this scan, what do we say? Is it a normal CT scan of the chest, or is it an abnormal CT scan of the chest? So if I talk about myself, and if I speak to Dr. Kamra, he'll also say that as radiologist, we've always learned that asymmetry, look for asymmetry. If I see an asymmetry, especially in places like brain, lungs, then we say it's abnormal. If we do not see an asymmetry, many a times we are tempted to think it can be normal. But that is where interstitial lung diseases take a toll. So they are often so symmetric. So when we look at this scan, this is definitely an abnormal scan. What are we seeing? All of this area, it is abnormal. Now how can I be confident that it is abnormal? Only when we keep an imprint of a normal HRCT in our mind. This is how a normal HRCT looks like. This is what is the attenuation or the shade of the normal lung parenchyma. As a crude comparison, what you can see is that this shade and the shade of the air in the trachea should match, should be similar. You look at this shade and you look at the shade of the air in the trachea, they are not matching. So that means it is all abnormal and it is normal. So you have to keep such a picture in your mind always, and anything which deviates from such a picture means that it is abnormal. Again we come to a scan like this. You see such a scan, you've sent a patient, patient comes back to you with such a scan. Now is it normal or abnormal? Anyone? How confident? It's? It might be. So we are not confident. We will not be able to send the patient back saying that it's normal or abnormal. What about this? When you look at this, now are you confident? It's normal. So that is the reason why I am stressing on a good quality scan. This is a scan which is without an adequate breath hold, and there is a transition between inspiration expiration leading to this motion blur and an apparent GGO, which makes you less confident about saying whether this patient is normal or abnormal. But when you see this, you know at least the lung parenchyma is absolutely normal. Again we come to a scan, we look at this scan. Now is it normal or abnormal? Abnormal. Why? Because we are seeing some GGOs. Yes, I show you same patient, same section. Now it's normal. What is the difference? This is a scan in good inspiration. You look at the trachea, it is round. It is a scan in good inspiration. In this scan, it's an expiratory scan. Expiratory scan has GGO, which are normal. So they are not actually GGO, we call them apparent GGO because the air has come out of the lungs and the lungs start looking denser. You see that it is in a gradient. So black, black, white at the level of the fissures. So this gradient is typical of a normal expiratory scan. So this is also normal, this is also normal, but our diagnostic confidence becomes much more when we look at this scan and say it is normal. So that is why it's very important to get your end inspiratory scans well. Now how do we differentiate whether what we are looking at is inspiratory or expiratory? You look at this scan, this is a round ovoid trachea. The posterior margin is also convex, it has a bulge. When you look at this, it is flattened or it is D-shaped. So when the posterior margin of the trachea becomes flat or D-shaped, then we know it's an expiratory scan. So whenever you look at something which you are tempted to call GGO, the first thing you should do is look at the trachea. If the trachea is round, that means it's a true GGO. If the trachea is not round, then question yourself again. It can just be a lung from which the air has expelled out and it is not abnormal yet. Now the question is, fine, we need good inspiratory images to be sure that it's a normal lung. Why do we need expiratory images? I've been saying that we need expiratory images, we should be doing. So why do we need that? So let's look at this example. This is a normal lung parenchyma. It's a good inspiratory scan and we are seeing nothing. So it's a normal lung. Now we can let the patient go saying the chest CT is normal. Whatever is the reason of your complaint, we don't know, but the chest CT is all normal. You've come with some cough, you've come with some shortness of breath, but the chest CT is normal. Now, the moment we do an expiratory scan, what do we see? We see these areas of air trapping very clearly. So, you see that this is black, this is whiter, and this entire area is black. So, this is an area of air trapping. So, you see those differences. So, the entire left upper lobe had constrictive bronchiolitis leading to air trapping. The patient had airways disease, which was the cause of her complaint. So, this apparently normal looking lung parenchyma had a dynamic disease. It had constrictive bronchiolitis, which could have been easily missed had we not done an expiratory scan. Similarly, you see that this is again very normal looking lung. The moment you do the expiratory scan, you see all air trapping down here. So, these things are accentuated only when you do an expiratory scan. Apart from being able to talk about airway dysfunction, the expiratory scans are of great use with respect to ILD in cases of hypersensitivity pneumonitis. So, this is an infiltrative lung disease. We are in doubt, it's an infiltrative lung disease. What could the underlying etiology be? We do expiratory scan and we see that it accentuates the mosaicism becomes more. That means it's an interstitial lung disease with a good component of airways involvement. Our differential narrows down somewhat to a point where we say if at all it clinically fits, it can be hypersensitivity pneumonitis. So that is why the dictum is that in all patients with interstitial lung disease, we should be doing expiratory scans, at least the first set. Then in the follow-up cases, the decision can be made basis if the first set was HP or not, or if the first set had air trapping or not. So if you want to monitor the air trapping, you continue with the expiratory sets in the follow-up scans. If the patient is a standard case of UIP, IPF without any air trapping, then in follow-up you can avoid the expiratory scans. Then we come to the question, we talked about the importance of inspiratory, expiratory. Now we talk about why a prone is needed. So again, I'm talking about a third set of scans. So the question is, why are we doing so many scans? What is the entire need? You do an inspiratory scan, the patient had CTD. Patient was sent to look for early ILD. The treatment will differ if the patient has only CTD or the patient has CTD with ILD, not so symptomatic. I do the scan, I see these basal reticulations. As a radiologist, I report that I'm seeing some basal reticulations, could be gravity dependent, could be CTD, ILD. Now, am I of any use if I give such a report? I am of no use because the entire context of doing the CT scan. So, telling a patient you are absolutely normal to telling a patient you have an ILD. There's a huge difference. So how do we bridge that gap? I do a prone scan and all of this disappears. So that's such a huge thing to a patient in labeling a patient as having an ILD, which becomes such a poor prognosis, to telling them that you're absolutely normal. Now, what is the difference? Again, you see a similar scan. You see these reticulations. I do a prone scan and these persist. Now, I am confident that yes, early ILD changes have started setting in this patient and maybe you can modify your treatment accordingly. There are times where prone may not be needed. So like for example, in this scan, I am seeing good interstitial thickening in the anterior zones, non-dependent zones. So there is no need of a prone scan in patients where you see fibrosis in a non-dependent zone. So just to summarize, this is the ideal scanning technique. So whenever you write an HRCT in a patient, especially when you're suspecting an interstitial lung disease, it's better to mention all of this in your prescription, because you don't know where the patient is going, whether they know of an ILD protocol or they don't. But if you mention expiratory, inspiratory, prone, they will understand, and even if they don't understand, they'll at least call you back to say that what do you actually need in this patient. So that's why it's very important. Now the various terminologies, once the scan has been done, right, it's easier to understand how these other terms with respect to HRCT appear on a CT scan. So it's very simple. Lung is black. Things blacker than black become low attenuation. Things whiter than the black becomes higher attenuation. So we just talk about various things in the lung parenchyma on a scale of gray shade. So very black to white, that is all how the lung parenchyma appears. It has very limited subset of appearance for huge variety of insults happening to it. So it's in that manner simple. When you look at a lung parenchyma, I showed you a normal lung image. So when you see areas in the lung which are darker or more black than what a normal lung shade should be, these are the few important differential diagnoses. So we'll talk about each one of them one by one. How do we label something as honeycombing versus emphysema versus bronchiectasis and so on. So honeycombing is one of the foundation or the cornerstones for ILD. The moment you write honeycombing in your report, or the moment you start describing your CT scan as honeycombing, the moment you use the word honeycombing, it automatically means you've labeled it as ILD, and that too a fibrosing ILD. So the moment you mention honeycombing, it becomes a fibrosing ILD, and hence it's very important, the onus is on you, it's very important that you should be correct when you are calling something honeycombing. Now what is honeycombing? These are these cluster of tiny cystic air spaces. So one important word is cluster. They cannot be solitary, they have to be in group, they are in layers then. They have to be in groups, then in layers. The layer can be a single layer versus multiple layer. They are usually subpleural in distribution. They share walls with each other. They cannot be separate from each other. So when we say in clusters, and then similarly they share walls with each other. And then there is significant associated architectural distortion in the lung. So when all of these 5 criteria are met, only then do we call something as honeycombing. Anything short of this, please question yourself again before calling it as honeycombing. So let's look at the other examples, how we differentiate the other low attenuation areas in the light of honeycombing. This is a typical honeycombing. So cluster of cystic air spaces sharing wall with each other, subpleural and architectural distortion. You look at this, again you are seeing blacker areas in this. They are low attenuation areas. But do they have walls? Are they in cluster? Are they sharing walls with each other? Is there architectural distortion? Is there subpleural distribution? Nothing. So we are very sure these are not honeycombing. This is centrilobular emphysema. Another example. So when I look at this, I might say they are subpleural, sharing walls, layered. But is there any architectural distortion? No. So again, this is not honeycombing. These are large paraseptal emphysematous cysts. You look at these clustered cystic air spaces. So I'm seeing clustered cystic air spaces, but not subpleural, all moving towards the hilar. At these points, it's also very important that if we have our images on DICOM series on our computer and we try to scroll through them, we will be able to see that these are all communicating. So honeycomb cysts are solitary discrete cysts. They do not communicate with each other. The moment you start seeing communication, that means they are bronchiectasis. So you look at these clustered air spaces, you know that if they are communicating with each other towards the hyaline, not so much subpleural, you know, and these tubular areas, you know, these are bronchiectatic changes and not honeycomb cyst. Then cystic lung diseases. So these are bizarre cysts. They are not similar sized, randomly distributed. A lot of them may not share wall with each other. The intervening lung parenchyma looks good. So a lot of the criteria are again not matching, and you know it's not honeycomb cyst, it is a cystic lung disease. So when you see these black areas, try to differentiate one from the other basis these criteria, and which will help you be wiser in labeling something or not labeling something as honeycombing. Then beyond those round areas, what else do you see in the lung parenchyma on an HRCT? Sometimes you see lines. So in a normal looking lung parenchyma, when a lot of lines are drawn, so we call them as reticulations. The terminology is reticulation. So when you have these lines, it becomes reticulation. Then these lines have character. It's not as simple as lines. Basis the character of those lines, you can narrow down your differential. Now, the lines can be irregular, they can be smooth, or they can be nodular. There are three prominent type of lines that you see in the lung parenchyma. We will look at them one by one. So this is how a normal lung looks like. I am just putting this image again and again because it's important to keep this imprint in your mind that this is how a normal lung looks like. Now on this normal lung, when you put a lot of lines, so how do you imagine this lung? So on this lung, a lot of lines have been drawn and they have been scribbled over this lung, and then you get this lung picture. So a lot of scribbled line. How are these lines? Are they very smooth lines? No, they are very irregular fuzzy lines covering the entire lung parenchyma. So what I am seeing is an irregular reticular pattern. When you see such an irregular reticular pattern, the important differentials or the entities which present with this are the UIP IPF or the chronic HP pattern when you see such irregular lines over the lung. Again, this is a normal lung, and what have we done? Drawn some lines over this normal lung. Do you see a difference between the previous lines and this line? These are more smooth, more well-defined lines compared to those fuzzy, irregular lines in the previous scan. So when you see such more smooth lines filling the lung parenchyma, then you think of pulmonary edema. You're also seeing effusion in this case. Smooth lines do not happen with interstitial lung diseases which are of fibrosing nature. So you do see them in entities like PAP where there is infiltration with fluid inside the interstitium, but not with fibrosis. So when you see such smooth lines, you should be thinking of pulmonary edema. Yeah. Look at these lines. So you'll be able to see them. So now this is a normal lung, and you are seeing all of this is lines. All of these things are not in this now. So all of these are smooth lines. Whereas if you go back and you look at this picture, you look at these lines, they are all hazy. So you see the margin. So try to put it like this, that if on this picture, if I give you this picture on a paper and I ask you to convert it into this, you will be using a pencil and just drawing it. Whereas when I ask you to convert it into this, your pencil will move like this in a hazy manner. So that's where these are irregular line versus these are smooth lines. That's how you can differentiate them. The third pattern is a nodular pattern. So now when you look at these lines, you are looking at lines, but what are you seeing? That at certain places there are nodules. So the lines are dot and line, so they are moving in that manner. So then we start calling this as a reticular nodular pattern. This reticular nodular pattern, when we see, we narrow our differential to either sarcoidosis or a lymphangitic carcinomatosis. These were the various reticular patterns in the lung parenchyma. The third pattern we talk about are nodules. So again in the lung parenchyma, the third way any insult can manifest is in a nodular pattern. Now again these nodular patterns, the nodules can be different. So the nodules can either be very discrete, well defined or ill defined nodules, and their distribution can be different. So depending upon the nature of the nodules and their distribution, we can again narrow our differentials. So let's look at this example. We are seeing some clustered nodules. So again, if I take the analogy of drawing with a pencil, when you are wanting to draw these nodules, you will sharpen your pencil and try to draw these nodules because they have such sharp margins. This is what I mean by discrete nodules. So these are very well defined discrete nodules, yes. And what is the distribution? Is it peribronchovascular, centrilobular, random? They are all following this peribronchovascular pattern. You are seeing them clustered. all clustered along the peribronchovascular bundle. So it's a discrete nodular pattern with peribronchovascular distribution. What are the differentials? Sarcoidosis and lymphangitic carcinomatosis. Another example where again on the lung parenchyma, what are we seeing? Multiple nodules. These are sharp, discrete nodules. I'll show you an example of ill-defined which will make this thing even more clear. So these are sharp, discrete nodules. And what is the distribution? Random. You cannot say whether they are centrilobular, peribronchovascular. So these are randomly distributed discrete nodules, which narrows our differentials to pneumoconiosis, miliary TB, which may present in this manner. The third pattern is this. So what are we seeing here? So I think when you are trying to decipher whether or not they are nodules, you are straining your eyes. These are not well defined, unlike the other previous two cases where the nodules were very evident. You could make, you were very sure that you are looking at nodules. In this case, this is what I meant by saying ill-defined. You have to strain your eyes to look at these nodules. So these are the ill-defined nodules, and the distribution of these nodules is typically centrilobular. Why do I say that? You see this black line towards the periphery. That means these nodules are not reaching up to the pleura. When they are not reaching up to the pleura, despite being so diffusely distributed, that means they are in the airway still. They are not subpleural, they are not in the interstitium. That means they are centrilobular nodules. Ill-defined centrilobular nodules are very, very characteristic of acute hypersensitivity pneumonitis. This is again an example of centrilobular nodules, and again you see that the immediate subpleural region is paired, but these are more denser. These are the typical infective inflammatory bronchiolitis, unlike the hypersensitivity bronchiolitis. So after these three patterns, another very common pattern in lung is ground glass. So what is ground glass? A whiter lung. More white than the black lung we have, but still not as white as a consolidation. So within these whiter areas, when you keep seeing these vessels, that means it is still a GGO. And again stressing on the fact that always comment on presence of GGO only on inspiratory images. Do not say GGO on an expiratory image. If it's just an expiratory image, ask for a repeat inspiratory image. Now the GGO can be in this distribution where we call it mosaicism. So there are patchy GGO like the mosaic floor, some GGO, some black, some GGO, some black, or sometimes the GGO can be like this, a diffuse sheet like distribution where it's involving the entire lung parenchyma uniformly. Among the high attenuation, another pattern in the HRCT is the consolidation. So consolidation is a whiter GGO where through those areas you are unable to see the underlying blood vessels. Then there are a few combination patterns, like you call this the atoll sign. So you have the GGO in between and consolidation towards the periphery. So when you see this, this is very typical of an organizing pneumonia pattern. This is the crazy paving pattern which I just discussed, that you have these areas of septal thickening. So smooth septal thickening and background GGO. So this becomes a crazy paving pattern, which again defines that there is some underlying infiltrative lung disease. Now that we've talked about the various patterns, so once you look at an HRCT and you are talking about an interstitial lung disease, the first thing is to figure out which patterns are affecting the lungs. So you say that maybe there is reticulations only, maybe there is reticulation with nodularity, maybe there is reticulations with honeycombing. So whatever patterns, basis what we discussed earlier, you've defined. The next most important step towards going to a diagnosis of an interstitial lung disease is understanding the distribution. So whatever insult is involving the lungs, so whether it's honeycombing, ground glass, reticulations, once you've defined the pattern, you need to also say how is that pattern distributed in the lung. So that distribution needs to be defined in two parameters. The first is on the axial CT scans. So you take a single set of the axial scan, and on this scan you try to say whether the disease is towards the periphery or it's involving the entire lung. So how do we define that? Maybe you can draw a circle in between and then ask yourself that whether the major bulk of the disease is outside the circle or it's inside the circle. So when it's outside the circle, the disease becomes peripheral. Once a disease is peripheral, you don't stop there, but you ask yourself the next question, that if it's peripheral, is it reaching up to the pleura? So in this case, if I draw a circle here, I see that the center is rather spared. The disease is peripheral, touching the pleura. So whatever pattern was there, whether GGO, reticulations, whatever was there, that distribution has a peripheral subpleural distribution. The other pattern can be subpleural sparing. So again in this case, if I draw a circle, these central areas are rather spared, the periphery is involved more. We can appreciate this better on the sagittal scans, and we see that the center is spared and the periphery is involved more. But then we move more towards the periphery to ask ourselves if this subpleura is involved. It's not. So this is again a disease with peripheral distribution but subpleural sparing. That information is very important, and we will see as we go ahead, and most of you also know that why that information is important. The other distribution will be diffuse axial distribution or a peribronchovascular, where even if I draw a circle here, I don't know whether the disease is more inside, more outside. So it's an ILD, maybe with reticular ground glass, whatever pattern, but it's peribronchovascular. It's involving the center as much as it is involving the periphery. So apart from the axial scans, the other way you need to differentiate or describe the distribution to come to your diagnosis is the zonal pattern. By zonal I mean top to bottom. Right now we were looking side to side, medial to lateral. Now we talk about top to bottom. So whether the disease is involving the apices more or the bases more. So then you need to, the third point you need to put beyond the pattern, the axial distribution of the pattern that you saw. Then how is the zonal distribution? So the top is involved more or the bases is involved more. So we see a typical basal lower zone predilection. Again, these things become much simpler the moment you have your images on your DICOM data set, because these sagittal recons are so easy. These things may look very simple, because when you are scrolling on the axial scan, ILD is such a diffuse and a gradual disease that sometimes our eyes get accustomed. You start seeing from top to bottom, you will not be able to differentiate whether bases were involved more or the apices. But the moment you put such a scan in front of you, a sagittal scan, you are seeing top and bases together, it becomes much more easier and your confidence interval increases. So like for example, if I look at this scan, by the time I come to down, I might have lost what was there in the apices. So you have to put either all of them together, so you know that this disease is typically upper zone predilection, right? So we have the upper zones involved more and the bases are spared, right? So these things become much more simpler when you have your sagittal scans. So coming to all of this, this is how a basic first line interpretation happens. So this is like putting the various puzzle pieces together. Once you've seen your HRCT, you know the pattern. Which amongst the patterns, what is the subtype of the pattern? So if it's a nodular pattern, whether it's discrete, what is the distribution? Once you've defined that pattern, you define the axial distribution, the zonal distribution. Once you put all of these pieces, you have all of these pieces together, now you just need to put them together to come to your diagnosis. If any of these pieces go wrong, then your diagnosis will go wrong. So that is why that systematic approach is important. And none of this is possible without a good quality scan. Simple things like whether it's basal predilection, whether it's subpleural sparing, whether there is ground glass, whether the ground glass has mosaicism or not, none of that is possible if your scans are not done right. So the bottom line is to get your scans done right, then start your interpretation, pick up the various clues, put them together, and now try to join the puzzle, which we'll be doing in the second part of the talk. So this is so I'll be happy to take any questions else.
Ma'am, I wanted you to again repeat the slide of peribronchovascular nodule.
So what do you want to see in this? So we are looking at cluster of nodules. Are you okay with that? this looks like random. So, well, that's where you have to see your scans and understand this is not random, because this is typically peribronchovascular. That's why I am standing here to say that this cannot be random. This is random. You do not, if you try to understand, you'll see a difference between how the nodules are distributed here versus how the nodules are distributed. So, that is what you need to get into your brains, that the only reason why you are thinking of calling this random is because they are so many. So, when they are so many, obviously something will spill over from the peribronchovascular to the other areas, but it's a continuum. So, when you try to see, you are seeing them in clusters. And you are seeing that all of these nodules are around the bronchus. Are they not? When you see the entire images, you will see them going through the subpleural region. You will, that is what you have to understand. You have to over time understand what is peribronchovascular interstitium versus what is a centrilobular interstitium, and those things will happen only when you start seeing your images again and again and over again. And trust me, there will be large number of times where there will be dilemma. That is why we are talking about ILD. It's not everything is even this clear. This is a very clear picture. But there are times when they are not even this clear, but that is where you'll have to understand, and over time when you keep seeing them more and more and more, you'll realize that these are peribronchovascular, subfissural, what are those areas in the lung parenchyma. You have to just keep reading and seeing them again and again.
I think, Dr. Khushbu, you can also show the fissural nodules.
Yeah, so that's what I did not put as, I have a sagittal image in the next where I'll try to show.
Because this is what happens when you see those fissural nodules, you confuse them that they are actually parenchymal, but not. It is because the fissure is not seen most of the time, but if you see this linear pattern, it is the nodules are along the fissure. So that may be the reason that if you are confusing it, actually it is because they are fissural as well as peribronchovascular nodules. So that's why it happens, but if you see it on the sagittal image, these would be very clear.
The moment you do sagittals, these things, they just unfold very clearly. So that's where, and I'll show you those things when we go through the live cases. I'll show you how that sagittal recon makes a hell lot of difference to what we are looking at.
Just wanted to add one thing. As she has mentioned that good quality scan is must. But to obtain that good quality scan, patient should also be able to hold breath for certain seconds. So when you send patient for HRCT protocol, you make sure that at least patient is stable for and able to hold breath. Otherwise, you do not expect the patient who is having rapid breathing that you will be able to obtain the good volume scan of the entire lung. So this I would like to stress, because many times patient come for HRCT and वो तो मतलब blade भी नहीं पा रहा होता है. So then in those situations you have to first manage the patient, and then only we will be able to obtain a good quality scan. No problem in that scan. Obviously we have to go and repeat again.
So sir, in those cases, exactly as Dr. Kamra is also saying, see, if that patient is in an acute exacerbation, MDD often helps. Then maybe from CT scan, the information that we are trying to get is that maybe if there is no superimposed pulmonary edema, maybe there is no superimposed infection. So those information we can still give with whatever scans we get. But yes, there are times, I mean, the machine cannot get a good quality scan on itself. It's a combined effort. So whatever you can do at your level to get the patient as stable as is possible. Obviously you have your constraints. At our level, what we can do is sometimes doing the patient in a prone position makes them much more compliant to an inspiratory scan. So the moment we do in prone, the information we get is a lot of shade better than what it is there. When you are sending your patient, you tell your patient that how a bit of training at your end does make a huge difference. So if you tell them कि वहाँ आपको machine बोलेगा सांस रोक के रखिए, आपको ऐसा 1 second सांस रोकना है, because you are the prime figure. The moment you accustom them to that scan, because most of the times when patient comes to us ना, they take all of us as technicians and they say, डॉक्टर साहब ने तो यही कहा था, आप ये सब क्या करा रहे हो, क्यों करा रहे हो? So when you've primed them that you have to do one scan in inspiration, फिर आप ऐसे breath hold expiration करके कीजिएगा, things become very simple. And at least I can assure that from a place where 10 of 10 scans were going wrong, even with breathless patients, we can get at least 6 to 7 of 10 out of 10 scans right with these simple maneuvers and a combined effort where it happens.
These patients who are in chronic respiratory failure,
Yeah.
and we ask them in ILD, and we are sending them for CT scan, it would be wise that we give them supplementary oxygen to correct the hypoxia.
Yes.
And
yes, yes.
that makes life more comfortable for the
Yes,
radiologist
exactly.
also.
Yeah. So those things, that is what, so those things sometimes if you inform at your end, most of these scanners also have a oxygen supply in between. So those simple things and giving them, telling them that take whatever inhaler is happening before your scan and do all of this. So those simple information from your end makes things much easier at our place. And at our place, things that we can do is just train them once again, do prone scans, and we are able to get a reasonable quality scan to answer our question.
Actually, the problem of our clinics is we are getting grade 4 patients. That is the problem, because we are expected to diagnose each and every patient, and the patient is in grade 4. So we have to settle the patient, and at least we will be getting some information from the CT scan where we are moving. So that
Very
is
true.
that is the difference, because every patient is coming to us with severe breathlessness. He is very hypoxic, is not settled, and then we are made to make the diagnosis on that only. That is the problem. And now people are coming with a lot of smartphones with their films, and they say कि वहाँ तो film खत्म हो गई थी, उन्होंने कहा इसको वीडियो कर लो, और वीडियो लेके आए हैं. And those CTs are really horrible. You are unable to diagnose, even make out anything out of it. That is the usual scenario we are getting.
So for that, a very simple, and in fact, to me this sounds promising कि अगर कोई उन्हें कह रहा है कि film खत्म हो गए तो, because the films are anyways obsolete. You cannot diagnose anything on films, and today every city, state, almost everywhere, we know it so well that the digitalization of radiology is phenomenal. We cannot say that it's a tier 2 or a tier 3 city where, so even in a tier 3 city, the digitalization is more. So then stress on getting a link. The moment you get a cloud link for your scan, you have an access to the entire scan. So even in films, what will you get? At the most, even if they try to, club up everything, 24 images in a film, maybe 3 films, 3 into 24, that too small images where you will not be able to decipher anything. Ask them, you don't need films, you just need that link, and that link will open anywhere, and you will be able to see that. You will be able to get second opinions, third opinions. You can send them in a flash of second to whoever you want to. You will not have to wait for the patient to do that CD.
Ma'am, I got 2 questions from the audience. One is clear these terminology, mediastinal window and parenchymal window.
Okay. So
Question number 1.
Yeah.
And question number 2 is, when should we order for a contrast HRCT?
All right. So both are very important questions. So when mediastinal window and parenchymal window, mediastinal window is the normal abdominal window. The black and white images where we do not see the lung parenchyma. They are to assess the mediastinal structures, the vessels, the lymph nodes. The parenchyma is the HRCT window, which I showed to you. So again, I will stress on one simple thing, that in current era, there is no acquisition of mediastinal or parenchymal. There is a single acquisition. These are all reconstructions. So once you've sent your HRCT or a CT scan to a center, what they have acquired will invariably have a mediastinal window. It will invariably have an HRCT. And again, at this point, I'll stress on the DICOM data set, because once you have it, you have the capability of doing mediastinal versus lung parenchymal window. Then the need for contrast. So for ILD, we do not need contrast per se, unless you're looking at a superimposed complication like some lymph nodes where you are suspecting tuberculosis, in which case if we give contrast, the delineation of caseation etc. becomes better, and the moment you see caseation, you tilt more towards tuberculosis or infection versus a sarcoid. So that's where contrast helps. Contrast helps in cases like infections, tuberculosis, malignancies. HRCT per se, contrast has no role.
Thank you. We have with us our senior person, senior pulmonologist, Dr. V.P. Agrawal sir. Please chair the session. And Dr. Brijen Chaudhary, please also join the chairperson.
Sir, so at our place what we do is we take a decision basis the supine scans. So when I am monitoring the scan, my technologist speaks to me, and if I see some dependent atelectasis, the question is whether it's an ILD or not, I'll do a prone scan. If the patient has come for a standard TB follow-up, even if I'm seeing those basal reticulations, they are not important for me right now, I do not do a prone scan. If a patient has diffuse flamboyant interstitial lung disease, again doing a prone will be of no help. So where you have a radiologist monitoring these scans, taking a call, it's not a mandate. But in places where you just send a scan, you don't know who will be seeing. At least for the first time for an ILD, ask for a prone scan.
I think a lot of basic questions have been solved. I will let Dr. Khushbu drink water and take a breath before we start with the next session on HRCT in ILD disease. Because see, with this baseline preparation, now we can do more justice to what is coming next to next level of learning.
With this, this will be my agenda. We've already spoken about what should be an ideal HRCT protocol. We've already spoken about how to interpret the various patterns on an HRCT. Now we will try to put those patterns in a systematic approach one by one so that we arrive to a etiological diagnosis. We will talk about what is an idiopathic pulmonary fibrosis and how do we differentiate those idiopathic varieties from the non-idiopathic pulmonary fibrosis, which is of utmost importance. I'll take a word on non-fibrosing. I'll not go in details of non-fibrosing maybe, and just a last word on the newer ILD classification by the ERS, which has come up very lately, and a lot of new terminologies. Some have generated a lot of confusion versus some have opened a lot of new avenues to think. So we talked about this ideal HRCT protocol, again stressing on this, that this is the one thing which is most important and you need to take from here, because the moment you have a scan with this protocol, then nothing will stop you from arriving to a diagnosis. So it will become much easier. Then we start, till now we were talking about interpreting the HRCT mechanically. We were talking about what does this look like, what are the various patterns. Now we come to the exact essence. So how do we diagnose them clinically? What does a pattern translate into a clinical diagnosis? So the first question when we come to an interstitial lung disease, when we talk about an interstitial lung disease, with respect to treatment, with respect to prognosis, what is the most important thing is whether that ILD is yet fibrosing or non-fibrosing. So you have an ILD, now the first important thing you need to know that whether this patient already has fibrosis versus it is still in the non-fibrosing stage. Again coming to the same point, that the moment you see honeycombing, you know it is fibrosing. We already discussed that these are the important attributes of honeycombing. So the moment you see these 5 features, you know it is honeycombing, and then it is a fibrosing interstitial lung disease. We discussed about the various differentials of honeycombing, wherein how to differentiate honeycombing from centrilobular emphysema, paraseptal emphysema, bronchiectasis and cystic lung diseases. So after that, now we are at a stage where we know that if it is honeycombing, it is a fibrosing ILD. What are the other features on an ILD that tell us that it is a fibrosing ILD? So if you see these areas of traction bronchiectasis, so you see architectural distortion, you are looking at an interstitial lung disease, there is no honeycombing, but there are these areas of traction bronchiectasis, then it still becomes a fibrosing ILD. if you see such reticulations, the irregular reticulations that we were talking about, then again this becomes a fibrosing ILD. So even in the absence of honeycombing, it can still be fibrosing ILD if you have either traction bronchiectasis or these reticular opacities. The moment we have either of these three, we have come from we knew it was an ILD, now we know it's a fibrosing ILD. Fine, but that also does not satisfy. So once we know it's a fibrosing ILD, the second question is it an IPF? Do I label it as an IPF, or is it one of the non-IPF fibrosing ILDs? Is it a chronic HP versus it's a sarcoid related fibrosing ILD versus it's a CTT related fibrosing ILD? So the next important question becomes whether it's a fibrosing ILD, this is what we know, but whether it's the non-IPF or the non-IPF category. How do we differentiate that now? For this, the ATS-ERS classification has come to our help. The moment we know it's a fibrosing ILD, we try to put it into one of these four patterns. In which does it fit most? And then we take it from there. So if that pattern fits into a typical or a probable UIP pattern in an appropriate clinical context, it can be IPF, else all other, I mean indeterminate or alternate, they should be non-IPF unless proved otherwise. So what are these typical UIP patterns? So this is a very typical UIP pattern. Now comes the place where you put the various puzzle pieces together and you see how and in which pattern are they fitting most. So when I am looking at it, I am looking at a disease which on axial distribution is peripheral and subpleural. On the zonal distribution, this disease has a basal predilection. It is a very heterogeneous disease. It is a disease where I talk about the patterns with a predominant irregular reticular pattern. Then there is honeycombing and there is absence of anything else as a prominent pattern. So there are no nodules, there is not GGO which is more than the reticulation. There can be GGO, but it has to be less than the reticulations. And then there is no consolidation, there is no mosaicism, there is no cysts apart from the honeycomb cysts. So when you see all of this, you know it's a typical UIP pattern. What is a probable UIP pattern? Everything else remains same, just that you do not have honeycombing, but you still have traction bronchiectasis or bronchiolectasis. So this becomes the typical and the probable UIP patterns. The indeterminate pattern is one of the wastebasket patterns where you are unable to fit the ILD into the rest of the three, but you still know it is ILD. There are some reticulations, you are not sure how the distribution is, whether it's basal, whether it's peripheral. So when you come to this category, it becomes an indeterminate category. It is one of the categories where you often need a biopsy to prove further. Alternative diagnosis is one of the most important categories. Why? Because the moment you put something into an alternate diagnosis, you know that this ILD has an underlying etiology. So then you have to aggressively work on the underlying etiology, because if we are able to figure out an etiology, the prognosis becomes better. So alternate diagnosis cannot be IPF unless they have been proved. Even with a histopath is not enough. So if an MDD with a histopath says it's an IPF, then maybe, but otherwise when it's an alternate diagnosis, it has to be a non-IPF ILD. What are the various features of an alternate diagnosis? So when in an interstitial lung disease, you start seeing cysts, when you start seeing extensive mosaicism on the inspiratory accentuated on the expiratory scans, when you start seeing GGO which is much more than the reticulations, you start seeing nodules in the lung parenchyma, you start seeing consolidation along with the interstitial lung disease, then it's an alternate diagnosis. Do not label it as IPF. You need to figure out an underlying etiology. It could be a chronic HP, it could be a CTD ILD, it could be some drug induced ILD or anything, but it is not an IPF. If you have a disease which has an upper mid-zone peribronchovascular distribution, IPF is either typical UIP pattern or probable UIP pattern. So it has to have a basal and subpleural distribution, peripheral distribution, whereas any distribution other than that means it's an alternate diagnosis. These are few things which on CT scan is important for us as radiologists, because you have the patient and you've seen them better. So now we come to a place where we are able to define as an ILD as a fibrosing ILD or not. Once we've defined that as fibrosing ILD, we tried to put it into one of the 4 ATS-ERS classification. So we saw it's a fibrosing ILD and it's also a UIP pattern. So it's a typical or probable UIP pattern. Now, do we label it as IPF? Does all of it become IPF? Or do we need to biopsy all patients before labeling them as IPF? This is an important question, that whether all typical probable UIP become equal to IPF or not, and if we are suspecting IPF, do we still need to biopsy to start the treatment? So let's see how we sort this problem out. This is where the MDD comes into picture, and this is an MDD. So a patient comes to a pulmonologist, you try to define that patient into a high versus intermediate versus a low clinical likelihood for IPF. You have categorized or triaged the patient basis the clinical picture of the patient. Now you send for an HRCT. On the HRCT, the radiologist says that it's a definite or a probable UIP pattern in a patient where you thought a very high clinical likelihood for IPF, or in a patient where you thought it was an intermediate clinical likelihood for IPF, but the HRCT is a definite UIP pattern. In both of these case scenarios, it becomes a definite IPF and you can start the treatment, no biopsy is needed. However, if we go opposite, I say that it's a definite UIP pattern, that means it's IPF. No. I say it's a definite UIP pattern, but you say no, this patient has a very low clinical likelihood to have IPF. That means it is not an IPF still. You need to aggressively evaluate, figure out some other underlying cause for the UIP pattern, and if still we are not able to come to a conclusion, then we figure out and consider biopsy to add on. Biopsy is not an endpoint. That's again something we need to be very sure of, that if a pathologist writes it's a UIP pattern does not mean it's a UIP pattern. If a pathologist writes it looks like IPF, it does not mean. It still has to come back to the MDD. We have to put the clinical picture. If the pathologist writes it's an IPF in a patient with a low clinical likelihood and in a patient where I was still not seeing a definite UIP pattern, it does not mean. So it has to come back to the multidisciplinary discussion again. So what we talked about the IPF fibrosing ILD. What are the other other fibrosing ILD? So the non-IPF fibrosing ILDs, these 3 are the most common, which carry the bigger brunt of the fibrosing ILDs. Let's talk about each one of them one by one. So one of the most common fibrosing ILDs, which is not an IPF, is hypersensitivity pneumonitis. Hypersensitivity pneumonitis is further classified in 2 patterns. It is either a non-fibrotic or the acute phase, and the fibrotic or the chronic phase. It also has certain very specific characteristic imaging patterns which can give us a clue, and where again with a good clinical index of suspicion for HP and a good HRCT which is giving those pictures, we can obviate biopsies. So like for example, if you have these centrilobular bronchocentric nodules, very typical of acute HP, the ground glass with a mosaicism. So you have ground glass, white lung, blacker lung. So you see 3-4 shades of gray in a single inspiratory axial scan. That is what we call mosaicism. So you are seeing infiltration, air trapping, normal lung all together. That is highly suggestive of hypersensitivity pneumonitis. You also call it the head cheese or the triple density sign. HP typically has upper lobe fibrosis, but the opposite is not true. So if you see an ILD with upper lobe fibrosis, think of HP. But HP also very commonly has lower lobe fibrosis. So if you are seeing lower lobe fibrosis, it does not mean it cannot be HP. So that is something we need to be sure of. This is what I was talking about. So when you have significant mosaicism, significant air trapping, which is much more than the reticulation, and a disease which is not peripheral, which is diffuse axial distribution, then the combination of these signs has a specificity of more than 90% for HP in a patient where you are clinically suspecting HP, so you may not biopsy these patients. This is the typical centrilobular nodules. So again we are seeing nodules, these ill-defined hazy ground glass nodules. You see the immediate subpleural area which is paired. Again you can call them as random because it is involving the entire lung parenchyma, but this is where you have to understand the pattern. It's not touching the pleura. How can it be random? Random nodules will not show such an organization. You look at this image and you see it's a very organized pattern in which these nodules are involving the lung. There is a very good organization, very good symmetry in which it is involving. So when you see such an organized pattern, how can it be random? Organized is opposite of random. So again you see these nodules. All of this is, I'm just showing these images to sensitize your eyes to what a centrilobular nodule means. These are often mistaken for GGO. These are also often mistaken for normal because our eyes sensitize and we don't realize. So when we are scrolling, we see very similar thing all over the lung. By the time we come down, we say it's all normal. So we have to sensitize our eyes to what is normal and then look at these abnormal. This is what is mosaic attenuation. So this is a good inspiratory scan. I am seeing white areas, black areas and intermediate areas. So when you see these different shades in a single axial scan, this is mosaic attenuation. There can be multiple underlying causes of mosaic attenuation which can vary from infection to malignancy. So you have to put it into the adequate clinical scenario. The upper zone fibrosis which I talked about in HP. So when you see this upper zone, peribronchovascular. So starting from hilar reaching up to pleura. So it is not peripheral. So it's a peribronchovascular upper zone fibrosis. Lower zones you are seeing the typical mosaicism. When you see this, it's a very typical book picture of HP. Not that you see that always. The stress on why expiratory image is important. So this is an inspiratory image. The moment you do expiration, you see that the air trapping, comes out so well. Your level of confidence that this patient has a concomitant airway involvement becomes much higher. So you are sure that you are looking at an interstitial lung disease. There is diffuse lung infiltration. But to be sure that there is a concomitant airways involvement, you need to do the expiratory scans. Once you do this and you see an ILD with airways involvement, you know that HP becomes a top differential. The third pattern that we see, so we talked about UIP, we talked about HP. The third pattern of insult in which the lungs can be involved is the NSIP pattern. The moment you see NSIP pattern, think of CTD. Idiopathic NSIP does not happen. So maybe the CTD is not a manifest as yet, it's still in the process, but the moment you see an NSIP pattern, aggressively look for an underlying CTD ILD. What is an NSIP pattern? This is a typical NSIP pattern. What am I seeing? I am seeing a disease which is predominantly GGO. So all of this is GGO. Again, when we compare the trachea with the lung parenchyma, there is a good difference in the attenuation. It is so homogeneous, so symmetric that again we can mistake all of this as normal unless we go to the bases and we see the ground glass becoming more apparent. So it is a disease with ground glass predominant abnormality, basal predominance, very homogeneous distribution. This is one of the USP pictures of NSIP. So it's very homogeneous, very organized. Subpleural sparing, you typically see these areas of subpleural sparing. So the disease is going towards the periphery, but it ends just short of the immediate subpleura. Very minimal reticulations usually, but we do see them with higher amount of reticulations. It's just because we are diagnosing them late. So then you have an NSIP without fibrosis and you have NSIP with fibrosis. When you see an NSIP pattern, there are often telltale signs that you can look for and which can make life easier. So you see this esophagus. This is dilated. This is a dilated esophagus. So I'm seeing an NSIP pattern. I'm seeing a dilated esophagus. This is a case of scleroderma related interstitial lung disease. Now, if it's an NSIP, it is equal to a CTD related ILD unless proved otherwise. That's how the dictum goes. But it does not mean that a CTD will have only an NSIP pattern. CTDs can also have a UIP pattern, because we did discuss that not all UIP is IPF. So what about the rest of the UIP? The rest of the UIP will either be CHP, or it will be a CTD ILD, or it will be a sarcoid ILD. So which UIP patterns, when you see, you should raise a concern for CTD. So there are certain signs on a UIP pattern also which give us a hint that there could be an underlying CTD and you should aggressively evaluate for them. These are the three typical signs. So the anterior upper lobe, again look at these sagittal images. What am I seeing? I'm seeing a very typical UIP pattern. So peripheral, basal, reticulations, honeycombing, nothing else. So it's a very typical UIP pattern, but I'm seeing this anterior upper lobe involvement, which is prominent. You look at the axial scans, you see the anterior upper lobe honeycombing. When you see this anterior upper lobe involvement, which is also known as the four corner sign, think of CTD ILD, especially if it's a young patient. So think of CTD ILD, aggressively again evaluate, maybe the CTD is just coming up. Yeah.
What is the four corners, and can you explain on this?
So by four corner we mean that in a UIP pattern, we've talked about basal involvement. So lower zone basal involvement, this becomes one corner. Right lower lobe basal involvement is one corner, left lower lobe basal involvement is two corners. When the anterior upper lobes also start getting involved, this becomes third corner and the fourth corner. So it becomes four corners of the lungs are involved, 1, 2, 3, 4. So in a routine UIP, IPF, only the basals are involved as much. When you start seeing the anterior upper lobes, it becomes the anterior upper lobe or the four corner sign. The other sign is the exuberant honeycombing. So you see an ILD, UIP pattern, but the honeycombing is exuberant to the extent that sometimes you want to call it a cystic ILD. So when you see such exuberant honeycombing, then you should be thinking of an CTD ILD. When you see the straight edge sign, so most of the times what happens that especially with the UIP IPF ILDs, it's a gradual disease. So a gradual disease will grade. So the lung will, it will start showing an involvement, increasing. It will go in a graded or a slope pattern. When you see such a sharp demarcation that the normal lung and all of a sudden the lung starts getting involved, that means it's a straight edge sign. When you see such a straight edge sign, think of an underlying CTD ILD. Then we were talking about the non-IPF fibrosing ILDs, we talked about chronic HP, we talked about CTD ILDs. The third most common non-IPF fibrosing ILD is the stage 4 sarcoidosis. So with sarcoidosis, there are certain patterns, yes, but as we all know, sarcoidosis is a huge mimic. It can present in any manner, but few signs where you should think of a sarcoidosis related ILD fibrosing is when you see a disease with upper mid-zone predominance, an axial or a peribronchovascular distribution, there is significant volume loss in the upper zones, and which is causing the fissural displacement. On the background, if you are able to figure some nodular pattern which is showing some fissural distribution, often it's difficult to find that. You see some symmetric hilar mediastinal lymphadenopathy, then obviously honeycombing can be seen. So when you see these, you can keep a concern for sarcoidosis. Similar pattern is seen with HP. Presence of lymph node does not mean it has to be sarcoidosis. You see lymph nodes with IPF, you see lymph nodes with HP. So none of this is the finding, but this is how a sarcoid fibrosing ILD presents. And if again put into a proper clinical picture and the clinical attributes of the patient, the diagnosis can be made. So it is one simple thing is that if we talk about NSIP, it's very homogeneous. Sarcoidosis is the most heterogeneous. A very heterogeneous fibrosing ILD with upper zone predilection, if you are seeing, you can think of sarcoid in the appropriate picture. So this is how it does look. It's more of perihilar, upper zone, you are seeing large honeycomb cysts, a lot of architectural distortion. So with this we come to the fact that how to diagnose whether an ILD is fibrosing or non-fibrosing. Once it's a fibrosing ILD, how to differentiate the IPF from the non-IPF category, and how to then subtype the various other non-IPF categories. Then comes the bracket of the non-fibrosing ILD. I am not talking about the imagings of these, but these are the names of the non-fibrosing ILD. They have different pictures. This is more of clinical attributes put in together with these specific clinical pictures that we come to these diagnosis. And now I'll just take up a few words on the new ILD classification proposed in 2025. So what happened with this newer ILD classification? See, it's difficult, it's confusing, but the entire idea is to ignite more conversation, to ignite more etiological diagnosis towards a particular ILD. They started dividing an ILD into two patterns. So they said that an ILD can start in the interstitium and ILD can start in the alveoli. Till now we were talking about an interstitial lung disease as an ILD starting in the interstitium. But with the upcoming of hypersensitivity pneumonitis, we saw that there was an airways component also. But whether that airways led to an ILD or the ILD was always starting outside. So those questions were ignited. So when we go to the pathological level, it was realized that there is an ILD which is in the peripheral interstitium, which becomes the UIP NSIP. Then there is an ILD which is in the peribronchial interstitium, which becomes the bronchiolo-interstitial pneumonia. This was a new term which was proposed in this newer classification. And then there are also ILDs which are smoking related, which are organizing pneumonia related, where you know obviously the insult is from the airways. So smoking related ILD will not start in the interstitium. A smoking related ILD starts from the alveoli and then it goes to the, so there they started differentiating. What is important is that these two new terms came up, the BIP pattern and the AMP pattern. AMP pattern is a replacement for DIP, desquamative interstitial pneumonia. The only reason they started saying is that earlier all desquamative interstitial pneumonia was equal to a smoking related pneumonia, but now they say that it's an alveolar macrophage pneumonia, which can be or may not be. There can be other insults apart from smoking. So obviously the environmental exposures, etc., which can be there. And then the BIP pattern, which is something which has raised a lot of controversy and a lot of discussions. Now what is a BIP pattern? So let's look at it very simply. When you see centrilobular nodules, mosaic attenuation and a 3 density sign, when you see this, what does it become? It becomes HP. So whenever we were seeing this, it becomes HP. Now they have just introduced a BIP in between, that whenever you see this, call it BIP. One of the subsets can be HP, but it can still be a CTD ILD, it can still be a drug induced ILD. So do not equate all of this to HP, because what happened with the discussion that HP is a very common interstitial lung disease, we started labeling everything with this as HP. And then if we did not find an underlying agent, an inciting agent, we said unknown agent. So that there's an unknown exposure causing this HP pattern, but possibly that was not correct. So this all started in a very similar fashion. Once upon a time, every reticulation, every honeycombing was IPF. We labeled everything as IPF. We never thought of a term like UIP. UIP was introduced in between, and they started saying that a part of it is IPF. A UIP can still be a CTD ILD, it can still be a CHP. So this entire BIP concept is from that do not label everything centrilobular, everything 3 density. If you do not have a proper clinical backup as HP, call it something else. This is just a few words on how AMP and diffuse alveolar damage, the two new terms which were incorporated, but then it's not relevant currently. I will just wind up with this simple diagnostic algorithm that I often use for the interstitial lung diseases. This is just a recap of all that we did till now. That the first and foremost thing is we try to differentiate whether it's a fibrosing versus non-fibrosing. How do you say that? Honeycombing, traction bronchiectasis or reticulations. If any of this is present, it becomes a fibrosing ILD. Once it's a fibrosing ILD, if it is a definite or a probable UIP pattern in a patient with a high clinical likelihood, that is more than 60 years of age, no other identifiable cause, you call it IPF. Rest everything. So if it's not a high clinical likelihood case, or if it's not a UIP pattern, then it becomes either a non-IPF fibrosing ILD or the non-fibrosing ILDs. IPF is never a non-fibrosing, so it's a non-fibrosing or a non-IPF fibrosing ILDs. These ILDs try to define the pattern, distribution, whether it's reticulations, whether it is nodularity, whether it is GGO, whether it is mosaicism. Basis all of these things, when you put them together, there are three most common: chronic HP, CTD ILDs, sarcoidosis. If you can even narrow down your differentials between these three, you'll be right 90% of the times. And that's how the entire maze of ILD can be narrowed down to a smaller list of differentials. The few simple take-home messages are, one of the most important thing is that an adequate technique is an absolute must. None of this makes any sense at all if the scan is not right. Try to get your scans on a cloud share mode. Whenever you are looking at a diffuse lung disease, just think about whether it's fibrosing or non-fibrosing. So if in a patient with a high clinical likelihood, he has a definite or a probable UIP pattern, call it IPF, start treatment. But everyone else requires a very aggressive evaluation for the underlying ILD. Hypersensitivity pneumonitis is very common, but do not label everything as hypersensitivity pneumonitis. Know that BIP is now there. If put it into a BIP pattern first, then try to pull it out from there. If you have a good exposure and all, call it HP. ILD with air trapping, think of HP. It's more of a BIP pattern. Something which is very homogeneous, think of NSIP pattern. Thank you.
Ma'am, can you throw more light on BIP again and AMP again?
Okay.
Which slides?
So BIP is bronchiolocentric interstitial pneumonia. So it is an interstitial lung disease which has started from the bronchiolocentric interstitium. It has started from the interstitium immediately adjacent to the bronchi. It has not started from the airways, but from the interstitium adjacent to the airways. BIP is the HP pattern. But over time we realized that a lot of patients who had an HP pattern did not clinically fit. So you could not find out an exposure no matter how hard you tried, and so they did not clinically fit. But then we were just labeling them as HP. So that is why BIP has come up now with the intent to figure out that in case a patient has this pattern but still a clinical misfit for HPE, what else should we be thinking of? So that is the entire intent. It is not a new pattern. It is a pattern which we've been seeing all through. It's just a new terminology, and maybe just stopping you from jumping to HP. It's a stop in between. That stop and think and then move to HP. That's perfect. So that's what it is. If you talk about AMP, so AMP is a term which has just come up to replace desquamative interstitial pneumonia. Again, with a very simple intent to give it a pathological understanding. So desquamative interstitial pneumonia does not have a pathology inside. When you talk about alveolar macrophage pneumonia, you can understand the pathology, a disease from the alveoli with macrophage predominant and a pneumonia disease. So that's why the terminology has changed, to give you a sense of the pathology as well, and also to accommodate few things more than smoking. DIP was equated to smoking. So that it's difficult to remove that out of people's mind now. Now if I try to tell you DIP can be something else than smoking, it will be difficult to get into people's minds. So the new terminology has come up that this AMP is in a way equal to DIP plus many more things. So that's how it is.
Very nice presentation, ma'am. Very nice.
There was wonderful. We went step by step in our learning, the way it should be. Any questions from the audience? Chairpersons, anything you would like to add on? Yeah.
Since we are talking of MDD, we have pulmonologist, we have radiologist, we have a rheumatologist here as well. Ma'am, a patient of fibrosing ILD, UIP pattern on CT, definite or probable. What difference does it make in the management if the UIP is due to IPF, due to chronic HP, due to a chronic CTD, or due to sarcoid, chronic sarcoid?
So I don't think I am the correct person
Yeah,
to
that is
answer.
why I said we have a pulmonologist, rheumatologist, radiologist.
This question we will take up during panel discussion at the end of the day, because see, we are moving step by step. First thing was we are doing the CT. So what does CT look like in ILD, how to differentiate. Next we will talk about ILD, and then we will do a panel discussion that would be MDD, what you're talking about. At what all these things, after all these things, how does it make a difference if it is a UIP on CT scan, and but the differential diagnosis have been different. It is not UIP is not because of IPF. It might be because of something else. How does it make a difference? There comes the role of MDD. We will do it in panel discussion.
So I'll just take the liberty of a simple word as a radiologist here. See, for me, anyways, it does not make a difference. But over time, I've realized that if we stop there, there is no evolution. I mean, today, maybe it does not make a difference. It means that every fibrosing ILD, you start antifibrotics. But if we start dissecting it, we've come to a place that from an ILD being a death certificate, we've come to a place that people with ILD are being treated. Why? Because we started dissecting it. At that, even today we say it's a fibrosing ILD, you'll start antifibrotics. What is the point of all of this discussion? Maybe today there is no point, but tomorrow, maybe 5 years, 10 years down the line, everything will have a treatment. There is evolution. So we cannot stop there to say that the management may be same.
It is similar what we were treating a blanket treatment with the steroids 10 years back.
Exactly, yes.
So
And
it has come
evolved.
down. It has come down.
Yes.
We have come a very, very long way. What we were seeing initially as a very fulminant ILD versus chronic ILDs and slow progressive ILDs. And I used to question Dr. Prasad ki, how is that some people are surviving only 3 to 6 months, the others are surviving 6 years. So that is now, it is slowly, the curtain is being off.
We have a topic on that, who will progress, who will not progress.
But the only thing is IPF versus rest of the things. It is only the IPF versus rest of that is the only thing. But it is definitely very important. We have moved much distance. What it was 20-25 years back.
See, if it's disease more than 200 etiologies, narrowing down the confidence limit of diagnosis is a wonderful thing.
And without surgical biopsy.
Without surgical biopsy, yeah.
Without surgical biopsy.
One thing, ma'am. Dr. Khushbu, very nice presentation. Congratulations to you. Explained deep and very well. Though for a pulmonologist it's a difficult topic, and to go through the
For us also it's difficult, as difficult.
HRCT many times it's confusing in spite of good film. But what I felt is that the clinician, the pulmonary or general physician should write in detail about the clinical history and presentation and finding. That helps a lot in making the diagnosis to radiologist.
Absolutely.
And what I felt, what is the role currently of this AI? Because these are emerging things and very, very large scale in every field, in medical field also, in making the diagnosis, in particular this ILD diagnosis of different types. The radiologist's role in making the HRCT diagnosis.
So that's a very interesting and a burning question. Now, the one bottom line I would say is AI is coming a big way. It has a phenomenal role and it will actually make lives easier. It will give us more time to do much better things and to decipher things more. One place where AI becomes difficult to interpret is if your scan is not correct. So if you want to use AI, You will have to get your machines, get the scans right. So once you've got your scans right, a good inspiratory, good expiratory, fed it into the AI with the algorithms, trust me, it will not be wrong because it's all mathematics. What we spoke right now was simple mathematical algorithm. That algorithm can be fed into AI, AI can come to a diagnosis, but then we'll have moved further. Then we'll need more. So it's not about replacing, it will add on. Currently, if I talk about the current role of AI, it has not gone to that step to be able to diagnose, but it has exceptional role in quantification. So when you use these AI tools, I mean, if I give you a visual correlate, I say, okay, 50% of the lung is showing fibrosis. The patient comes for follow-up and you ask me, it has progressed or not. Okay, it looks like some progression, but if I give you numbers, last time there was 30% fibrosis, today it is 40% fibrosis, that is possible with AI. And it makes it simpler.
Yes, I do agree. Because we only not to add the CT findings, not only the radiologist finding, but also to mention the clinical sign, symptom,
Yes.
and findings in detail in making the diagnosis, if I have not written to the radiologist.
Yeah.
In that way, and
needs to be
also
very
our
clear.
sense and knowledge have to be applied in making the
yes,
diagnosis.
yes.
Thank you so much, Dr. Khushbu. A very nice presentation.
Would you all like to have a quiz? Yeah, sure.
Less than a minute. Just as you have mentioned so many diseases to the end point on CT, just a word on what actually the radiology report should carry in the end. Like you mentioned the 4 points which should be there, definitive, probable. Just a point for the clinicians that this is what the radiology report should in the end write for them to make it into a clinical decision.
So a typical report, I did not put a sample, but the way I put my ILD report is I will put it as pointers to make it simpler for AI in going era to pick it up. So I will put it as whether interstitial abnormality present or not present, what is the distribution, zonal or not, peripheral or subpleural, ground glass present or not present, again with the distribution, nodules present or not present, air trapping present or not present, and then MPa-AA diameter, which becomes important, increased or not, cyst present or not present. So all of those 5-6 attributes which I said. The bottom line of my report mentions, it starts in that fashion that number one, I'm seeing there is a fibrosing interstitial lung disease with a definite versus probable versus alternate diagnosis versus indeterminate pattern. So one of those 4 ticks. So it's a fibrosing ILD with this pattern, which now that becomes fibrosing pattern. Then I come to etiology. So if I say it's a fibrosing ILD with a definite UIP pattern, now in this patient, which is say a 70 years old male, so I say in this 70-year-old male where I know there is no other identifiable etiology, I can label it as IPF. Again, if it was a 40-year-old female, I would have said I'm seeing a fibrosing ILD with a definite UIP pattern, but in this 40-year-old female, we need aggressive evaluation for an underlying etiology. If I said it's a fibrosing ILD with an SIP with fibrosis pattern, then it needs an aggressive evaluation for an underlying CTD ILD. If it's a known, then I say it is consistent with the underlying CTD.
Thank you, Khushbu ma'am, for your nice presentation. One question that in as a 25th 2025 new classification of ILD in a diffuse pattern, right? There is a bronchiolitis, or you can say the organized pneumonia. In old patient, elderly patient, it has been seen that they are suffering from multimorbidities and mixed multimorbidities, where there is degenerative change in the lungs. On radiological basis, because we are physician, we cannot describe so much as like you in the radiologist. So how you will differentiate in organized pneumonia or bronchiolitis and degenerative change in the lung above the 70 or 75 year old person?
Whoop versus degenerative changes.
Yeah.
Worse. So perfect. So BOOP, or when you're talking about the organizing pneumonia pattern, they have a very typical peribronchovascular consolidation like patterns.
Consolidation.
So if we are trying to differentiate now, maybe if I'm getting it right, we are trying to differentiate whether that consolidation is due to some active pathology versus some chronic pathology. That is what we mean by degeneration. So active versus active, when we are talking of active, it becomes things like infection, things like malignancy, where you have that organizing pneumonia pattern, versus if that organizing pneumonia is a cryptogenic organizing pneumonia related to some interstitial lung disease. So that often requires a clinical acumen and a clinical presentation put in together. Organizing pneumonia is just a pattern. Then to label it, so if you tell me, no, this patient has had this pattern for last good long 5 years, he's been living with this pattern, we know it's not a part of the spectrum. And so,
But further evaluation is necessary because it mimics like a malignancy or
yes,
maybe
so there, in case the further evaluation is first is an MDD. So if you see that pattern, you need to speak, and then MDD does not need to be everyone sitting together and talking. I can just pick up my phone and say that, okay, I'm looking at that organizing pneumonia pattern, how has the patient presented, is the patient febrile, is it not? So that becomes the first step of looking at it. The second step can be if we think a contrast study is needed to be able to differentiate things better, and then we take it from there.
Thank you, ma'am. Thank you.
That was a wonderful session. Do you all want a quiz to be held so that we can just recapitulate the whole session?
We can do that.
Ma'am, are you ready for that?
Perfect.
You need a break?
No, I'm okay.
Perfect. It's good to have such energetic speakers with us. So now we are going to have a small quiz on HRCT. Dr. Khushbu will take it from here. And the questions will be here depicted for all of you, displayed for all of you. And I would appreciate that all of you participate in it and come out with the right answer.
So this is very simple. We'll go very simple step by step. We will not try to jump on any conclusion. We'll see how that, moving step by step makes us different and makes things much easier for us. So we look at this. This is the case 1. It is a 40-year-old female with joint pain and progressive breathlessness. My first question is very simple. What you saw, was it a fibrosing ILD or a non-fibrosing ILD? Fibrosing. We are all on the same page. It was a fibrosing ILD. Perfect. Now what is my next question? So we go just simple step by step. It was a fibrosing ILD, but which amongst these patterns did it fit in most? So was it a typical UIP, probable UIP, NSIP with fibrosis, or a lymphocytic interstitial pneumonia pattern? I can show you the image once again so that, so this is the pattern that we were. So this becomes typical. We were seeing a disease with peripheral, basal, subpleural, honeycombing, reticulations predominant. It's a typical UIP pattern. Perfect. Now we come to the next question. It is a typical UIP pattern. So is it an IPF? Is it a chronic HP? Is it an end-stage sarcoid? Is it a CTD-ILD?
CTD-ILD.
Perfect. Why is it a CTD-ILD?
There is exuberant honeycomb.
Exuberant honeycombing. If I ask radiologically, 40 years old female, joint pain, progressive breathlessness, most likely to be a CTD-ILD. Perfect. So now we come to the next case, 20-year-old man with breathlessness for last 2 months. So this is the HRCT picture. Again the same question, non-fibrosing. So no honeycombing, no reticulations, no traction bronchiectasis. It's a non-fibrosing ILD. The second question is, which is the least likely diagnosis? Least likely. Perfect. So why miliary? Because we saw some nodules which were not random. So you are seeing some GGO, very homogeneous, could be an NSIP ILD, could be respiratory bronchiolitis ILD, but yes, not a miliary because these were not discrete nodules. Next, a 53-year-old woman with breathlessness for last 5 years, gradually progressing. So this is the HRCT picture. Fibrosing, perfect, it's a fibrosing ILD. What is the pattern? Probable UIP? Okay, I'll go back to the image. What is probable UIP? Probable UIP is a disease with basal lower zone predilection, peripheral subpleural distribution. It is everything like a typical UIP, but No honeycombing. So I'm seeing honeycombing, I'm seeing a disease with upper zone predilection, I'm seeing a disease which is diffusely involving, so there is no periphery. So what is this? It is not typical, it is not probable, it is not NSIP. NSIP is a very homogeneous looking disease with ground glass as the predominant. This is so heterogeneous. You are seeing the upper lobes involved and the lower zones not involved. So let's go back to the options again. Alternate diagnosis. So whenever you see a disease with upper zone peribronchovascular distribution and so much of mosaicism, look at the lower images. NSIP is very homogeneous. NSIP is homogeneous, NSIP is lower zone. NSIP can be peribronchovascular, but NSIP is homogeneous, it is lower zone with much less honeycombing and bronchiectasis. So this is an alternate diagnosis. This is an alternate diagnosis. The other question is, yes, it's an alternate diagnosis, but what is the underlying etiology? What are you thinking of? I'll put the picture again. An upper lobe peribronchovascular fibrosis. In the lower zones, we are seeing some, what is the pattern that you are seeing in the lower zone there? GGO? Yes? GGO has a diffuse distribution or there are patches? Patches. What does patch mean? Lobular, mosaicism. So the moment mosaicism word comes in, it becomes HP. Yes. So we are looking at an alternate diagnosis and a chronic HP pattern. Okay. Then this is a 72-year-old man with progressive breathlessness over the last 1 year. So we go fibrosing. Perfect. We are all good and at the same page. What is the pattern? Typical UIP. Why? Because we were seeing lower zone predominant disease. We were seeing honeycombing, reticulations predominant. So it's a typical UIP pattern. Then is it IPF, chronic HP, end stage sarcoid or CTD ILD? IPF. Why? 72-year-old man, typical UIP pattern, and we are assuming there is no other identifiable etiology. It becomes an IPF. Perfect. It's a 34-year-old lady with new onset breathlessness. What are we seeing? Is it fibrosing or non-fibrosing? Why non-fibrosing? Just because you've already made it up in your mind that it's an NSIP. It is an NSIP, but you're seeing reticulations all over. What are these lines? Are these lines or not? Are these lines or are these GGO? What are these? Are these lines or all of this is just GGO? There is GGO, but there are interspersed significant lines. So especially on the axial, if you see, it is not GGO. It is when you try to put GGO, you'll put lines also on this. So there are reticulations with GGO. The moment you see reticulations, it becomes a fibrosing ILD. You're jumping to a diagnosis of NSIP and hence you are calling it non-fibrosing. You're not going systematically. It is a fibrosing ILD. Yes. Now if you come to this, we call it, why? Because there was a very typical subpleural sparing, and I think all of you picked up that subpleural sparing well. Because there is subpleural sparing, it is NSIP. Because it is NSIP, it is non-fibrosing. That's how you all went. It's a fibrosing ILD with subpleural sparing. So it's an NSIP with fibrosis. And she was a 34-year-old female. So most likely to have a underlying CTD. So I think those are my...
Thank you, ma'am. That was a wonderful session. Dr. Tandon is there? No, Dr. VP Singh is not here. Okay, I would request Dr. Pankaj Kamra, please felicitate your honor as speaker.
Thank you. Thank you so much.
Thank you. Yeah. Sir.